East Kent were one of 8 sites who were awarded funds from the Health Foundation to use a new methodology called Safer Clinical Systems.
This is a sort of a quality improvement we've developed over the last year, working closely with the CCG, looking at improving the care of older people in the community. So we're targeting sort of high-risk, vulnerable, frail care home patients and trying to proactively manage them in the community to try and reduce the risk of unplanned hospital admissions, and also to give some choice about where their care is delivered in the future.
First and foremost, the residential homes or nursing homes are their home. The care staff are familiar to them, the surroundings are very familiar to them, so they're comfortable taking them into the acute setting, which immediately starts with the ambulance journey to hospital, waiting in A&E and waiting for further assessment. With all the busyness that is happening all around, can make for very uncomfortable periods of stay within the hospital setting.
From the outset, we met with the CCG leads to explain our difficulty, because this whole project started around looking at why frail, vulnerable people were readmitted to hospital repeatedly, often without an intervention.
East Kent Hospitals had the diagnostics and the findings from the diagnostics. CCG had the funding, and working together, we both had the vision to be able to put into place a new service within the community.
So I'll go out to the care home or domiciliary visit, review the patient, review all the notes, try where I can also to speak with family members, obviously care home staff, work out what it is the patient wishes for themselves long term, and put in place a plan to address any complications that may arise.
We were specifically looking at reducing readmission rates in older people at the William Harvey. Through the course of the first sort of 6 to 9 months of the project, we've reduced unplanned readmissions by around 4%, so from a figure of around 19.5% to just over 15%.
Harbledown ward is a 24-bedded ward which mainly deals with frail patients of all ages, but most of them are actually older people. Each morning we have a board round where every patient is discussed and their discharge plans are communicated to all the members of the multidisciplinary team.
In the old days, what used to happen was somebody would come into hospital with an older, frailer person would come into hospital with an acute medical problem, and they would go to an acute ward, and then we would try and get them better from that acute medical problem, and then realise that they weren't very good at walking and they were falling and all those other things, and we couldn't send them home, and then we would transfer them to a rehabilitation ward. So it was like a 2-tier system. And by the time you'd been in hospital for a week or two, things had got much, much worse. So we changed that system to set up this newer approach, which is that frail people of whatever age, but mostly older, often with comorbidities such as dementia, incontinence, falls, Parkinson's, those sorts of people would come into hospital and they would go directly to that ward. So we have everything you need for an acutely sick person, right up to cardiac monitoring and all those sorts of things. And then, but we would work right from the very beginning to keep them mobile, and it works incredibly well. When we first started up this process with the multidisciplinary team, we were all people working for the Acute Trust. But now we've managed to coordinate and communicate well enough with our colleagues from social services so that a member of the social services team attends the Frailty board round every morning, and that has completely revolutionised it.
There's been a huge amount of work from the medical staff who were like Claire Beeson, who was the principal coordinator, but all the other disciplines, as I said, nursing, the physio, OT and social services, they've all worked incredibly hard to get this off the ground.
We've worked quite closely with urgent care in trying to push forward ambulatory pathways and develop new models of care.
So ambulatory care is a new and emerging way of delivering same-day emergency care. One of the things we've managed to do is move from a system 5 or 10 years ago where we were dealing mainly with conditions such as DVT to a range of conditions now which can be managed through same-day emergency care.
We meet on a regular basis and discuss how we're going to develop the pathways, and then they do all the paperwork side of things, and we obviously put our nursing and clinical skills in to the development of those pathways. Every year we're working on further pathways and implementing but it takes quite a lot of work and time, and working with the CCGs to make sure that everything, you know, is right and safe for the patients.
So what we want to do is make sure that we deliver appropriate care for patients in the most appropriate environment. And we know now that we've got access to diagnostics, we've made access to senior clinical decision makers much more easily available. And we know that we've got access and communication with teams in the community who we can continue care with.
It wouldn't have been possible to develop ambulatory care as we have developed without the coming together of all the different disciplines of the clinicians, the nursing teams, the management teams, the finance and obviously information teams. And again, obviously taking on board the agendas of the CCGs and, you know, pulling together with them as well to ensure we're moving in one direction.